Jaishankar. I'm one of the general pediatricians here with ETSU Pediatrics, and I'm so excited to hear this talk. Dr. Will Dodd, one of our general pediatricians, adolescent medicine physicians, is going to introduce Dr. Kathy Edwards, zooming in all the way from Vanderbilt for us.
Before we get started here, I'd like to please remind everybody to log in to the CME system just to track attendance as well as continue our talks. So today's a genuine pleasure to introduce Dr. Edwards. I could spend probably half of our time here reviewing her impressive CV, but I really don't want to detract from her talk time, so I'll attempt to summarize. Dr. Edwards is a professor of pediatrics at Vanderbilt University School of Medicine, where she holds the Sarah H. Sell and Cornelius Vanderbilt Endowed Chair in Pediatrics. She's led many of the pivotal trials of vaccines licensed in the past several decades, and she plays a major role in the implementation of childhood vaccine programs. She has experience leading all phases of clinical studies on vaccines and therapeutics. Many of these have been multi-center NIH-funded initiatives. She has numerous teaching and mentoring awards, and she's mentored many of the investigators who lead vaccine research programs globally. She leads the CDC-funded CISA site at Vanderbilt, which monitors adverse vaccine events. And in 2011, she was awarded a CDC contract to conduct comprehensive pneumonia surveillance studies in adults and children with CAP, and she helped establish both the burden and etiology of this common disease. She's authored over 560 publications and has received numerous research and leadership awards. She's on the editorial board of Journal Pediatrics, Journal of Infectious Diseases, Pediatric Infectious Disease Journal, Infection and Immunity, among others. And she's the associate editor of Clinical Infectious Diseases. She served on numerous national committees, including currently on the membership committee of the National Academy of Medicine. And we are very fortunate to have her here to speak at ETSU Pediatric Grand Rounds on vaccine development to prevent respiratory disease from influenza and SARS coronavirus 2. So, Dr. Edwards.
Thank you. Well, I'm really pleased to be here and to talk to you about respiratory diseases. As Will and I were talking before we started, this is an extraordinary time. And as we, every year in this, when the leaves start to turn, we begin to think about influenza, but only in a pandemic are we also thinking about COVID. So what I'd like to do today is talk a little bit about both of them, talk a little bit about how we, the similarities in the two viruses and some of the challenges. And then I'd like to leave you at the end with a little bit of an update on what is happening both with influenza vaccines, but also with COVID vaccines. So I do serve as a consultant and on a number of data safety and monitoring boards where I look at the safety of vaccines that are being studied and before they're licensed. So what I'm going to do today is really talk with you about a few of the unique challenges of influenza virus and the vaccines. We know that we have vaccines that we use. We know that they certainly have an important role. We also know that we need some new vaccines, ones that would be wonderful if we didn't have to give influenza vaccine each year. It would be wonderful if our influenza vaccines were as effective as our measles vaccine. So certainly we want to talk a little bit about what's new with influenza. And then I'm going to spend a fair amount of time going over what we know about the vaccines for SARS-CoV-2. And then I'm going to talk with you a little bit about how they're licensed and implemented. And then there should be time at the end for you, for us to talk and address any questions that you have. So influenza is a continual problem, just like income tax. It comes every year. By and large, influenza viruses that infect humans are of two general types: influenza A viruses and influenza B viruses. The viruses are characterized by the hemagglutinin, which is these red bars, and the neuraminidase, which is on the surface of the influenza virus. And these surface proteins are what we give and what we hope to stimulate in terms of antibody to these proteins in our vaccines. But the influenza virus is very, very capable of because its genome is segmented of shedding one of its hemagglutinins and getting another one, so that often we must face every year at least one or multiple changes in the vaccines. We know that influenza A can infect multiple species, and we know that certainly pigs and birds are infected by influenza. And we also know that pandemics of influenza happen when the influenza A strains are passed from birds and pigs to people, and that's kind of what happened in 2011. We know that the influenza viruses cause epidemics and pandemics. Let's hope we don't have another one of those for a few years. And we know that influenza virus, in contrast, only infects humans. It tends to be somewhat less severe with lower mortality rates than the influenza. It can be associated with epidemics, but not pandemics. And as you know, over the last several years, there have been two lineages of influenza B, Yamagata and Victoria. So what we used to have as a trivalent vaccine being 2 A's and 1 B, now we have as 2 A's and 2 B's. And all of the pediatric vaccines that are licensed and are available to give to children now in the United States have 2 A's and 2 B's. So they are indeed all quadrivalent. Now, human influenza virus is certainly an acute febrile respiratory illness, and we know that fever and feverishness and cough and sore throat are certainly manifestations of influenza. We know also that it can cause more severe disease, both primary and secondary pneumonia, and interestingly enough, it can also cause croup. Not as commonly as para-influenza, but it can cause croup. And we also know that even though RSV is the most common cause of bronchiolitis in children, that influenza can cause bronchiolitis in little children as well. We also know as pediatricians that simply having fever, a very high fever without other symptoms, such as this very fussy little baby that we see up in the right-hand corner, this baby had influenza and had high fever alone. And we know certainly that there are neurologic manifestations of influenza being encephalitis and seizures. There can be myositis and there can be cardiac involvement as well. So influenza is a big problem in children. We also know that it has an enormous burden in our population. And I think one of the things that we keep hearing in the media is, well, how does flu compare to COVID? And I think that just looking at last year, 2019 to 2020, was a very bad flu year. Overall, in the United States, it was anticipated that there were about 50 million illnesses. There were about 500,000 hospitalizations. Now, this is adult and children, and there were about a mean of about 50,000 deaths. Now, certainly we know that over the past 7 months, COVID has caused 200,000 deaths. So certainly COVID is a bigger killer than influenza. But we know that they both are really important pathogens. We also know that for influenza, there is variability in the severity from year to year, and I'll come back to that in just a minute. The other thing that I think is amazing about influenza is that we know that when children, and particularly young children, get infected with influenza, amount of virus is really, really large. It's much, much larger than it is in adults. And that's probably because children haven't seen influenza repeatedly like we have and have not developed the immunity mucosally, or so that children have really high rates of symptomatic disease. They also are the major spreaders of influenza in the community. And they tend indeed to have more severe disease and death than the middle-aged people. And so that's kind of a difference between COVID, and that's one of the most fascinating things that I think about COVID, is that by and large, flu really hits the kids, but COVID has hit the kids, but not as severely as we see with influenza. Most of the information about influenza each year is from high resource settings, and we really do have a way from the CDC to look at the burden of disease. This is a slide that was taken from the CDC Flu View website, and this is a great website that you may want to just kind of check. It sort of tells you the numbers of cases. It tells you the numbers of flu cases in Tennessee. It tells you the number of cases in other parts of the country, and it also gives you the numbers of people that have been vaccinated. But what you can see here is that last year was a pretty long year. It actually had a lot of disease, but when COVID came, it markedly declined, and we'll go over that in a minute. But you'll see there's some years, such as 2011, 2012, which is right after the pandemic, that we didn't see much. So indeed, influenza is quite variable in its presentation. We also know that each year, around 100 to 200 children die of influenza. By and large, these children, a small percentage of the children that succumb to influenza have been previously immunized. We also know that over half of the pediatric deaths that occur each year are in previously healthy children. Certainly some are in children with underlying diseases, but half of them are previously healthy. And we also see that looking at last year, there were almost 200 deaths. So this is something that I think people don't always understand, that influenza can cause severe disease in little children and within individuals less than 18. This is an observation that looked at the different kinds of flu strains that circulated last year, and you'll see a lot of them were H1N1. You see a little was H3N2. You see a fair amount of B, which is this green, but then you see this precipitous decline in the cases in influenza, whereas it began kind of a slope, but you see an absolute shutoff. And what happened there was that when social distancing and when in the middle of March, when things were really closed down, that it became apparent that the contagion, that influenza stopped as we were trying to get better control of COVID. So one of the things that's going to be fascinating, and data already that suggests that it may be that even though we all need to get vaccinated, it may be that with this masks and social distancing, that we may be able to control influenza in ways that we haven't been able to before. If you look at the Southern Hemisphere, and they just got over their flu season when we have our summer, there was very little influenza disease in the Southern Hemisphere, suggesting that maybe social distancing and some of the masking things that were going on in the Southern Hemisphere are going to cause a reduction, or did cause a reduction in the Southern Hemisphere, and maybe we will see that. And so that will be really important for us to see. So there are a number of challenges with influenza. It's constantly changing. There are non-specific clinical manifestations. The burden varies from year to year. The vaccine strain must be changed frequently to capture the circulating strain. And we still, at this point, don't have a clear idea how the interactions with COVID are going to occur. They're really not very well characterized. So what can we do about this? Well, every year, both the CDC through their MMWR and the American Academy of Pediatrics come out with their recommendations for prevention of control of influenza in children for the upcoming season 2020 to 2021. And the bottom line for all of that, as it has been for a number of years, has that routine influenza vaccination of all persons greater than 6 months of age should continue and is highly recommended. And certainly being able to prevent influenza that might make it more complicated to see whether a patient with respiratory illness has COVID is a very important goal. Now, I want to spend just a few moments going over the influenza strains this year. I know many of you have already begun to give them, but I think there's a couple points. First of all, as I said before, all the flu viruses are quadrivalent. And the thing that is interesting this year is the H1, the H3, and the B Victoria. All of those are new strains. So these are 3 new strains that were not in the vaccine last year. So people wouldn't have pre-existing immunity to them. So that's an important point. The 4th, the Yamagata B was in the vaccine last year. This is a slide that shows all the options that we have for influenza vaccine in children. Most all of them still are egg-based, but there's a number of different companies, and we'll go over that in just a second. There also is a cell culture-based vaccine that is made not in eggs, but that's only for children over 4 years of age. And again, the live attenuated vaccine is available in children who do not have high-risk conditions from 2 to 49 years of age. Now, one of the things that probably you're going to see over the next few years is that there are going to be some new vaccines that are going to use higher doses of influenza that are egg-based. And there's one vaccine that is in study now that's looking at that. The other question will be whether adjuvants will be used. And at this point, there are no adjuvants that are used in any of the flu vaccines in children. They are in adults, and those do tend to be more effective in adults. But at this point, we have mostly egg grown, we have a few cell culture for the bigger kids, and the live attenuated. And there is no preference over one vaccine over the other being expressed by the CDC or the Academy of Pediatrics. As you know, there are a number of different strains and concentrations of the egg-based vaccine depending upon which pharmaceutical company provides it. You do need to know that some of the vaccines have more antigens in them than others, and you just need to carefully look at the dosage. There are not any recommendations to give the higher dose over the lower dose. Although if you look at the immune responses to children that get higher amounts of antigen, they tend to be a little higher than those who get smaller amounts. And just to remind you too, that you always need to ask if children have not had a previous dose, then you need to give 2 doses in the first year they get vaccine. If they've had a previous dose, then only 1 dose of this vaccine. The precautions and contraindications are pretty minimal. Precautions, well, first of all, the history of an allergic reaction to the vaccine or of its components are contraindications. However, as you probably are aware, the ACIP has felt that there is, and also the AAP, that there is so little egg in the vaccines that are egg-based that it doesn't represent a major threat, and so that persons with an egg allergy can receive the influenza vaccine. If people are uncomfortable with that, sometimes they will recommend them to or refer them to the allergist who can watch them, but the amount of egg in the vaccine is really very small, and the precautions are a moderate or severe illness with or without fever and Guillain-Barré within 6 weeks following a previous dose of influenza vaccine. However, Guillain-Barré is exceedingly uncommon in children, and so this is rarely a precaution. Now, one of the things that the CDC has done over the past several years is provide us with ongoing information about how effective the vaccine is. And this is primarily done by some sites that are funded throughout the country that provide information right back to the CDC, and they compare influenza cases in those children who are vaccinated and those who are not. And what you'll see here is from the Academy report. And overall, you'll see that for influenza A and B over the last several years, that the vaccine is between 30 to about 50% efficacious for the different vaccines. We do see that it tends to be higher in those children that are 6 months to 8 years of age, as you can show here, between 68% to 48% effective. And I think one of the points that is important for you to make is that if you have a vaccine that's, let's say, half is 50% efficacious, that means you prevent 50% of the disease. And so obviously with a large number of cases of disease, a large number of cases of illness, prevention of 50% of them is a large number of cases prevented. The other thing that we've been able to show, and these are some data that we obtained in our big pneumonia study that we looked at several years ago, that it does seem that the influenza vaccine is more effective for prevention of severe disease than it is for outpatient disease. And in these data, you'll see here during this year that for prevention of influenza pneumonia in hospitalized children, it was around 75%. So that's another point that I often make to parents, is that it appears that the vaccine for both adults and children is more efficacious for prevention of severe disease than mild disease. How are we doing? Well, as pediatricians, in terms of influenza vaccination coverage, we are doing better in that in those children that are 6 months to 4 years of age, about 75% of them were vaccinated in 2018, 2019. Overall, about 50% or 60% of the population is vaccinated, and certainly in those children that are 13 to 17 years of age, it's around 50%. So we are not certainly at any 100%. I think that as pediatricians, we're doing better than most, but I think it's also an area where we could certainly improve. I want to spend just a couple moments talking about some new options. And so you may have heard in the news that a universal influenza vaccine is being studied. And what is involved in that is that the hemagglutinin, which you see here is looking kind of like a tulip, that the stem of the hemagglutinin on the flu strains doesn't doesn't change very much. It's very conserved. So there are now some new experimental vaccines that are looking at if we could give more of a vaccine that is based on the stem, then maybe we would be able to generate a broader immune response, and maybe we would not have to vaccinate every year. So those studies are in progress, but they are not in children yet. They are not ready for prime time. And the new approaches that we see are likely going to be increasing the dose of the vaccine or the potential of using adjuvants. The other thing that I wanted to just briefly mention before we go into COVID, and that is that as you know, for children that are hospitalized with influenza or children that have high risk conditions, antivirals are recommended. And so this is something that I think that particularly those children that are hospitalized, the data show that the administration of the antivirals early on in the illness can be very helpful. And these are the doses of oseltamivir. There's also a newly recommended antiviral called baloxavir for children over 12, and that's just given as a single dose, and so that is also licensed as well. So those are treatment strategies for influenza. So influenza is a common respiratory illness. It accounts for substantial morbidity and some mortality. The influenza vaccines are safe and effective. Their absolute efficacy varies year by year. New vaccines are being developed. The prevention of influenza is really important during the pandemic, and antiviral agents should be used in hospitalized and high-risk children. Now I'm going to shift gears and I'm going to talk a little bit about what has consumed us all for the last 7-8 months, and that is the novel coronavirus. This is the first paper that was published in the New England Journal of Medicine in January 24th and talked about a novel coronavirus in patients with pneumonia. I think none of us had any idea what it would mean at that time, but certainly we have seen it evolve into a very big problem. Now, one of the things that I'd like to highlight, however, is that we had 2 other really severe coronaviruses that occurred. So this isn't our first bad coronavirus. The first one, the SARS-1, was started in Hong Kong. It was 800 cases, 10% mortality, which is pretty amazing. And that occurred in 2002 to 2004. That went away by strict infection control, and that virus is no longer alive. It does exist in some freezers, but it is not circulating and has not been circulated since 2004. The MERS coronavirus appeared in 2012. And that has had fewer cases, around 2,500. Its mortality is around 30%, which is even higher than SARS-1. But it is very localized into a few countries in the Middle East. And then SARS-CoV-2 or COVID-19 is the disease. The virus is called SARS-CoV-2. And as of 2 days ago, there were nearly 40 million global cases and 1 million deaths globally. So it is clearly the granddaddy of these 3, or grandmother of these 3. We do know that there are 4 circulating coronaviruses that cause colds. And one of the interesting questions is, how did they evolve into a sort of puny virus that causes colds? And one hypothesis that I have yet to have proven, but I thought was fascinating, was that there appeared to be a really bad flu outbreak in 1895 in Russia. And some people think that maybe that was a coronavirus that somehow has become one of the coronaviruses that circulate. But again, that is just a hypothesis and has not been proven. But one of the things that I want you to realize is that these 2 earlier coronaviruses allowed us to get a bit of a head start, because we were starting to make vaccines for SARS-CoV-1 and MERS. And I want to go over a little bit of that so that you think that, obviously we've done a whole lot of stuff in a short period of time, but we had done some work before. So one of the things that I think you see every night on the TV, you see that you watch the news, you see this big coronavirus with these red spikes. And this picture is a little bit different in that the spikes are blue and they're not red. But these are the important parts of the virus. Just like hemagglutinin and neuraminidase, which are out there on this edge of the influenza virus, the spike protein is on the edge of the coronavirus. And this spike protein is what interacts with the host cell. And if you take that spike protein over here, there is a special point, this purple part on the spike protein, and that's called the receptor binding domain. And that is the exact part that attaches to the cell to cause an infection. So what we're trying to do is we're trying to make an antibody to set on this purple receptor binding domain to block it so that it cannot interact with the cell. So that is the concept that was being used to develop vaccines for SARS-1 and for MERS. So that has been present. We've known that from the beginning. And there are a number of different ways to make the vaccines. And these are highlighted here: RNA, DNA, protein, carrying a little of the coronavirus in another kind of virus, an inactivated and a live attenuated. So there's a lot of products. Over 100 products are being evaluated in animals, and around 40 or 50 are being evaluated in people. Just to show you here, these are kind of the 4 broad categories. And I think these are the things that you kind of need to remember. That some of the viruses are just the coronavirus. So there's a big study that's going on in China where they're giving just a killed coronavirus, just formalin inactivated, just like we do with flu. They're giving it to large populations, to the military. And so that's how that vaccine is made. There are also some vaccines that are live weakened vaccines, like our flu mist, that are being studied, but none of those are in patients yet. And so that you would be a little worried to think, well, maybe those could revert or they could combine. So those are still in the test tube. The next one then are these viral vectors here. And viral vectors are a little bit like a Trojan horse. And what happens is that you load that spike protein, either the DNA for that or into the Trojan horse, and then the Trojan horse carries it into the person. Now, these can either be Trojan horses that are weakened live viruses that replicate, or they can be non-replicating. They can be dead viruses that carry the Trojan horse. And there are a lot of these products, particularly the non-replicating. We'll talk about that in a second. The other vaccines that have never been put in people before are DNA and RNA vaccines. These are really easy to make because when the Chinese published the DNA sequence of the vaccine, then people could just take, of the virus, they could take that off and they could begin to make vaccines. So these are the ones that are in the furthest ahead in study because they're easy to make. However, they've not been used before in licensed vaccines, although they have been used in MERS and SARS vaccine. And then finally, the protein-based vaccines. And these are just the SARS spike protein that can be given as a protein or with an adjuvant. And so there's a lot of those as well. So basically, there's a lot of ways to give the vaccine. And I'm going to go over some of those. Now, what we need to think about is that this isn't the Super Bowl. We want everybody to win. We want, if we could have each of these vaccines be safe and effective, that's what we would really like, because we have to give these vaccines to 8 billion people. And some of these vaccines have to be given twice. So we don't want a winner, we want a bunch of winners. So I'm going to go over 3 prototype vaccines that'll show you a little bit how these vaccines are made and a little bit about their safety and their effectiveness. So the first vaccine that went into people is what's called an mRNA vaccine. And what that is just the mRNA that codes for making the spike protein. Just remember your old genetics. And so here's the mRNA, and it's put in a little lipid coat, and you inject that into the muscle, and that coat comes off, and the RNA goes into this protein-making machinery of the host cell, of your own cell, and makes this viral protein. And this nice viral protein then is circulating in the bloodstream, and the body says, aha, I've never seen this before. I'm going to make an antibody. So what you're doing then is giving the message, and it's making a protein, and the protein then is stimulating antibody and T cells. So the first of those vaccines was the first report of that vaccine, of the first mRNA vaccine, which is made by Moderna was published in July 14th. So obviously very, very quickly done. And what you're going to see here is basically these are levels of antibody with the vaccine, and what's in the box are levels of antibody that are people that have been convalescent from COVID-19, people that were really sick and were convalescent. And what you see here is this vaccine at the various doses here is comparable to what you get when you're infected. And these are just different ways of looking at the antibody. And it doesn't mean, it really is not relevant. One of it is this receptor binding domain, which is, I showed you that purple part. And you'll see there's high levels of antibody to that purple part, comparable to what you see with disease. So again, it looks very immunogenic. We do, however, see that the vaccines are associated with side effects. So this vaccine must be given as 2 doses. This is the first vaccine. This is the second vaccine given a month later. These are mild, little bit of sore arm, moderate, and severe is pretty significant sore arm. And so you see that with the second dose of the vaccine. And I like to kind of show that it's pretty similar to what you're seeing with the Shingrix vaccine. You're getting kind of a big boost. You're getting some fever. You're getting to feel a little bit bad, but you do. It does have a punch with it. So that's the mRNA vaccine. The next vaccine that I'm going to talk about is a vaccine that you've been hearing in the news. And this is called this is the Oxford vaccine. This is the AstraZeneca vaccine. And this is a vaccine, the Trojan horse vaccine. And what happens here is that spike protein was put into an adenovirus. And one of the things that we want to make sure of is that this is an adenovirus which people haven't seen, because if they've seen before, because they've been infected, they may have antibody. So this is a chimp adeno, and most of us don't get chimp adenos. And so what you'll see here is that with this vaccine, with 1 dose or with 2 doses, you'll see that the antibody titers are very similar to the convalescent plasma. Now, what you also know is that AstraZeneca paused a vaccine trial for a safety review. And what happened in one of the patients of the several thousand was that the patient got transverse myelitis, which is an inflammation of the cord. And the question was, was it due to the vaccine or was it not? And obviously, if you have 1 case, it's very hard to know, but the FDA equivalents all over the world said that they felt that it wasn't that the safety profile still looked fine, so they could restart the trials. But this particular vaccine trial is still on hold here in the United States while the FDA looks at its safety. The final prototypic vaccine I'm going to talk about is just a protein vaccine, and this was recently published in the New England Journal. But this protein vaccine has an adjuvant, kind of like that adjuvant that you have in the flu vaccine. And what you see here is that this vaccine, in terms of antibody responses, actually is somewhat higher even than what you see in the convalescent plasma, as you see here. So it's really immunogenic, and the same down here when you look at a different kind of assay where this one is actually neutralizing the virus, you'll see that the titers are really, really high. So this looks like the antibody titers generated for this vaccine looks very, very high. This vaccine has not yet gone into small studies, but not yet gone into the 30,000 people that are, but that will happen very soon. So just to show you then exactly what is happening, this is a summary of what's going on in the United States. So the US put a lot of money into what's called Operation Warp Speed to fund a lot of vaccine trials. And there are currently ongoing or will begin very soon 6 large trials. The Moderna and the Pfizer vaccine trials started in July. They are mRNA, and remember I said those are ones that were easy to make and quick to get out of the box. So those are have nearly enrolled all of the patients. The chimp adeno, the Oxford vaccine, started in August, but this study is on a hold because of the transverse myelitis case that's still being evaluated at the FDA. The Janssen adenovirus is the same concept as the chimp adeno. It's only one dose. However, as you probably read yesterday or the day before, it also is on hold for a reaction that hasn't really been characterized in the media. So I don't know exactly what it is, and that is being evaluated. And then the Novavax and the Sanofi vaccines have not started their clinical trials, but they will be very soon. So what has the FDA done to give guidance about which vaccines will be licensed? And I must say, no matter whatever your political implications, and I'm not going into this at all, but one of the things that has been so exciting about the FDA vaccine guidance is that it has been really science-driven. And it has been, clear guidance has been given about what will have to happen for a vaccine to be licensed. So the FDA, as you just saw, there will be multiple efficacy trials. The FDA says that the vaccine has to be at least 50% effective with a lower bound of the confidence intervals of 30, or the vaccine will not be licensed. So they are not going to license a vaccine that's 10% effective. So that's a guideline. The second thing is that they are requiring 30,000 people to be enrolled in each of these phase 3 trials. It must be randomized. And the reason for that so many people have to be enrolled is because they need to see that it prevents COVID disease. And the primary outcome of those vaccines will be the definition of laboratory confirmed symptomatic COVID. Now it may be, you don't have to be hospitalized with that, but it does have to be illness and confirmed. The subjects that are enrolled, there's going to be, there's also more outcomes, more serious outcomes. They're going to be following all of the COVID positive patients to see the severity. They're also, these subjects are, because they want to be able to look at the impact and to see whether this is effective, then the people that are enrolled in these studies are high risk. A lot of healthcare workers, older individuals, people with chronic conditions, and minorities. I am participating in the Moderna vaccine trial. I'm one of the participants. There's also multiple blood draws to look at if there could be some level of antibody that's determined that's protective, and there will be long-term follow-up for safety for all of the participants for at least 2 years. Now, I want to spend just a few moments talking about safety assessments, because you are going to have to talk to people about the vaccine safety assessments, because people do not understand this. And so I'm going to go over this, and certainly I'm happy to answer any questions. All of the participants in these trials are having meticulous attention to capturing their local and systemic reactions. You indeed participate by every day after you get the vaccine. There is a message on your cell phone. You have to take your temperature. You have to talk about all of your, whether your arm hurts, whether you have lymph nodes that are swollen. You have to talk about whether you're tired, whether you have any kind of fever. You have to take your temperature and all of these things. So all of the participants in these trials have been given explicit instructions and the wherewithal with thermometers and text messages to meticulously recall their local and systemic reactions. So these are daily cell phone queries. If you have any symptoms of COVID, if you have cough or runny nose or fever, then immediately you are asked to come in and have a COVID test done at no charge. And then you are followed very carefully to see if you're positive. If you're positive, you have a pulse oximeter that you take home, and the nurse calls you every day and they ask you what your pulse, what your saturations are. large numbers of participants are going to be recruited. So we're going to have, hundreds of thousands of people participating in these studies. And, usual vaccines from pediatric vaccines, even in the rotavirus, they're not hundreds of thousands of people. So there's a lot of people that are going to be recruited, that all hospitalizations and serious reactions are assessed, that there are data safety and monitoring committees that are independent of the pharmaceutical companies that are going over each of these reactions, that if there is a significant reaction that causes concern, the trials will halt. And there's already 2 trials that have halted. And there are independent data and safety monitoring committees to monitor these trials that are independent of the pharmaceutical companies that will have the power to halt the studies if there is a signal. Now, certainly this is a challenge to vaccine assessment. The accelerated development is a challenge, and some of these new vaccine platforms have never been put in large numbers of people, and the RNA and the DNA vaccines have not been used to license other vaccines. The other challenge is that the vaccinations are occurring in a relatively short time frame with a relatively short follow-up. And given the rates of disease, it's likely that the efficacy signal will be reached within several months. So only giving people the ability to look for a couple months of after the vaccination for long-term side effects. The other thing that I want you to realize is that bad things happen that are not related to vaccines. And this is something that appeared in the H1N1 pandemic. And I think one of the things that's really important for you to realize is that you have to understand what the background rates of certain problems are without a vaccination program. Drink of water here. Excuse me. So just looking at Guillain-Barré, and these are from large databases, just looking at Guillain-Barré, even without any kind of vaccination, there are going to be a number of cases of Guillain-Barré. And depending upon, for instance, per 10 million people, there's going to be 21 cases of Guillain-Barré in 20 million people within 6 weeks, just by normal rates. And so you see the baseline over here, the baseline for the rates, you'll see, depending upon what exists, there are certain baseline rates. So that's also hard, is how do you know whether this happened as relationship to the vaccine or independent of the vaccine? And the other thing that we have to always think about is that it's all about risk and benefit. And, maybe we should, be very happy to tolerate a pretty sore arm, or even a day where you stayed at home because you felt pretty crummy, to prevent COVID. And so those are kinds of questions that are really hard and really complicated for people to address. The other thing that I wanted to leave you with, and hopefully we'll have some time for questions, is that there are tremendous numbers of people that are really worried about vaccines. So you are going to have to provide information. And this is a survey from Annals of Internal Medicine several months ago. It's about 1,000 people and kind of equally distributed between age groups and males and females. And there's more white non-Hispanics, but there's a smidgen of all kinds of racial and ethnic diversity. There's a fair number of differences in educational and attainment, although the whole waterfront is kind of covered, as is income and marital status and geographic region and setting. There's more urban than rural. And I think one of the things that I wanted to just focus on is the groups in each of the participant categories that say yes emphatically for the vaccination in a high percentage are people over 60, males, whites, college graduates, and people that make over $100,000 a year. In contrast to those who say no, are distributed more commonly in the other groups. And certainly when you look at racial and ethnic minorities, here we have 20% of the non-Hispanic Black are saying no to the vaccine. 21% of non-high school diploma people are saying no. And if you look a little more in terms of that, if you look at the people that are not sure, and these are going to be the people that you're going to have the most, you're going to have to help and understand, because they have special concerns about the vaccine. 60%, they want to know about the safety, the efficacy, the newness, the rigor of testing, what's in the vaccine. They also want to know some additional things. What does this mean for me with my allergies? What does this mean for me? And what are you telling me to do, doctor? I want to do what you're telling me. What are you going to do? And then the anti-vaccine attitudes, beliefs, and then lack of trust and others. So these are people that are not sure. And then there are those that are no, and these are going to be much more difficult to convince, if possible, to address. And interestingly enough, if you look at those, the large percentage are really against vaccines. And certainly we know that this is a challenge in social media as well. So I wanted to kind of end that I would like to make you feel comfortable that strong science is really a necessary starting point, that the FDA is not loosening their standards, that it's going to be really important for you to understand the vaccines, to be confident in them, to understand the answers to the questions, because trust in this is really paramount. The other thing that you're going to need to understand is that after the vaccines are licensed, there's going to have to be careful follow-up of adverse events. And this is going to be important as well. If you see patients that have an adverse event that you don't know about, or that please report it. And we will have, through the CISA network, we will have a 24/7 answering service to address some of the questions. In terms of pediatric trials, the FDA just gave approval today that Pfizer vaccine can go down to age 12. So they will be enrolling children down to age 12. If the vaccine looks safe and effective in that, then likely we'll go down into younger groups. And there are a number of protocols. All of the other companies are planning on doing trials in children. In addition, there are protocols that are being written for pregnant women, and those will be coming online soon. The other thing that you need to realize is some of the speed of all this is because, usually this whole vaccine procedure, phase 1, 2, 3, takes about 6 to 10 years. But what's happened here is we've really telescoped it, but then we've also put all of the risk in terms of making plants and doing all this vaccines. We don't even know yet whether vaccines are going to work, but we have these new plants so that we can make millions of doses of, we hope will work. And so that obviously has been part of the challenge as well. And finally, how these vaccines are going to be used will be really the CDC with the ACIP, and also the American Academy of Pediatrics will be working on guidelines for that as well. There will be prioritization of priority groups of people that having more disease as well. So in summary, safe and effective vaccines that are accessible, affordable, and globally available are needed for COVID-19. There is a robust pipeline of promising candidates. There's a lot of safety systems in place, and the studies are large and will likely reach efficacy endpoints very soon. So thank you very much, and I will be more than happy to take any questions. I'm sorry I don't have as much time as I had thought, but I can answer questions pretty quickly. Thank you.
Thank you, Dr. Edwards. That was a really great presentation. And are there any questions from the viewers?
I have a question about the mRNA vaccine, Dr. Edwards.
Yes.
So you mentioned that the mRNA, the DNA and RNA vaccines are not ones that have been used in humans prior. So is there any background? Do we know what sort of side effects to expect? Do we have any even sense if it's something that's not been used in the past?
So the mRNA and the DNA vaccines have been used in small trials with SARS and MERS. So they have been used in probably somewhere between 50 to 100 individuals for SARS, and same for MERS. So there are limited numbers of studies for that. This will be the largest population in that. We do know that from some recent data that was published in the New England Journal, we do know that the first information looked like that the immune responses in the people less than 50 were good, and then as RNA vaccines. The DNA vaccines there are a number of those that are doing phase 1 trials. There are not yet any plans for a DNA vaccine in phase 3 trials. The DNA is more difficult because what you have to do is with the DNA vaccine, you give the DNA, but in order to get it into the nucleus of the cells, you have to give a shock. So you have a injection, and then you have kind of what looks like a little pencil, and then it kind of has a little shock. Now it's not terrible. It's not putting your finger into an electric socket, but it is a little bit of a jolt, and how and whether that could be something that would be able to be used, so that's a little bit of a more complicated, but no, your point is well taken. We don't have a lot of information about those vaccines. We do have a fair amount. We also have, we have data from non-human primates of those, but again, we don't have, data for 10 years. We do have a couple of challenge models with the RNA vaccines and actually all the vaccines where the animals are, where the usually chimps are given the vaccine and then they're challenged with COVID, and by and large they're protected from pneumonia. Some of them will have a little runny nose and the virus may be in their nose, but they're protected from pneumonia. But no, there are that the number of people that have been studied will, it'll be very important that we continue to follow them. Thank you. Have other questions, or I can give you my email, and
Dr. Edwards, I'm one of the pediatric oncologists.
Yes.
With ETSU. How do you see the vaccination of the immunocompromised patients?
Okay, so I think that there are a couple things that we can do. First of all, the vaccines are the non-replicating vectors don't pose an infectious threat. So it wouldn't be like, giving a measles vaccine to one of your patients, which certainly you wouldn't want to do. So that's one possibility. There have been no studies at this point in any kind of immunocompromised individuals. Some of the people in the large efficacy studies are well-controlled patients with HIV, but they are not immunocompromised. They have normal CD4s and CD8s. One of the things that we may find for particular patients that are at high risk and also that may have trouble making antibody, even though the vaccine may not be harmful, but might be the use of monoclonals. And so that's a lot of work that is being done with monoclonals. And so that may be a possibility. And as you know, some of the monoclonals now, particularly with RSV, can be made so that they have a longer half-life. So that may be something that we'll be doing. There are several prevention trials using the monoclonals in nursing homes and families that have been exposed to COVID. So that may be a possibility. And I would almost say that might be something that would be more testable a little bit earlier. And so those studies may indeed be planned. Any other questions? Okay. Well, I want to say thank you. I really appreciate it. And if there's other outstanding questions, please let me know, and I'd be happy to answer them. Thank you so much.
Thank you for an amazing talk, Dr. Edwards.
Thank you so much.